Next up is Dr. Shute, and we'll get your slides up.
Great. Well, thank you and welcome, everyone. This session is really, I think, entitled Implementing Choosing Wisely in Washington State. And so clearly what we want to do is more than just talk about this, more than generate enthusiasm and understanding. We want to change how medicine is practiced. And so my task with this next half hour is really to transition from kind of the general to the more actual specific and action-oriented of what we can do within hospital systems, within clinics, to actually change how we deliver patient care and change outcomes. So I want to start by asking, who here works in an organization that delivers patient care? Fantastic, because you are really our audience, and you are the folks that we want to send home with some ideas and, quite frankly, an agenda. The purpose of my session is to talk a little bit about maybe the how, in a strategic level, to begin to shape these recommendations into practice, and then seed you with some ideas. So that's really the objective for the next half hour here. And this is a repeat of the slide you saw before, but the point of this is, Choosing Wisely is about helping physicians engage in conversations with patients, but to help patients make smart and effective care choices. Now, what I want to emphasize here is it's about helping patients make smart choices. And I think this is intentional and very careful to make it clear that this is A, very patient-centric, and B, that it's really not about our taking choice away from patients. I think when we begin to consider implementing this in a healthcare system, it's important to remember that at least the initial intent of Choosing Wisely is very, very patient-focused. I think our task as organizational leaders is to think about how can we help support physicians in this task. Again, of informing patients, but yet it is still their choice. So moving from recommendations, the Choosing Wisely recommendations, to implementation, I think takes a bit of a frame shift that I want to walk you through quickly. Again, Choosing Wisely is very patient-focused. It's about choice, and it's really about preventing or protecting patients from care that has low value or even has the potential to cause harm. And that's really where it comes from. But it is very much patient-centric. As healthcare leaders, our job is to help our organizations to be patient-centric, but at the end of the day, we really need to be organizational-centric. So without being a heretic, if you will, I would say that our job as organizational leaders is to assure the robustness and the vitality of our organizations. Otherwise, they will not exist to provide care in the future. So my suggestion is to think about how we can apply these recommendations in changes that will actually strengthen our organization while serving patients. And I think that's part of the art of process improvement and system improvement. We've all seen guidelines or recommendations that we believe are true, and they're either extremely difficult to implement or perhaps even harmful to our organizations. And so I'm going to try to think a little bit, help us to think a little bit about how we as system leaders can begin to sift through the guidelines, implement these in ways that actually will be successful, will strengthen the organization, and really get the outcomes we want. So here are really sort of my 5 pearls, if you will, to think about while going through and implementing Choosing Wisely recommendations. And I will say, when I heard the title of this talk was Implementing Choosing Wisely, I kind of thought to myself, you can't really do that. Choosing Wisely is recommendations, and really they're recommendations to stop and think and talk. You don't really implement that. Implementation to me means system change, right? Some permanent, embedded system change that changes processes of care. That's what implementation means to me. So as we think about this talk, think about bridging these guidelines to actual concrete system changes that will be successful. This sort of list I'm going to offer you now really apply to any system change, to any process improvement work. I will give you Choosing Wisely examples to help apply them. But that's where I want to go to next. How do we get this done? And the 5 general ideas are, first, look for win-win-win recommendations and try to design win-win-win implementations. And what I mean by that is think through your stakeholders and try to think of ways to start that will be wins across the board. And I'll talk a little bit more about what I mean by that. Second, leverage alignment. There's a tremendous amount of activity going on around us in the community, within our organizations, and we are fatigued, and our providers are fatigued. We should be careful to align both to prevent increasing that fatigue, decreasing focus, but actually building on the energy that exists. The third, provide useful data. All of us know how important that is, and in a minute I'll give you some examples of how to use that. Understand financial implications, understand the business case. I'm all for doing the right thing and using that as sort of the guiding principles and the energizing factors, but to get this done and keep it done, it will require savvy thinking about the business case. And lastly, support behavior change. Design systems that make the right thing to do, the easy thing to do. So let me take you through a few of these. So create that win-win-win situation. What I mean here is to think of key stakeholders. At the very minimum, it should be our patients, our physicians or our providers, and probably our CFO. Because if you think about any system change, if there's major blowback, to borrow Bill's word, or a major problem in any of those key stakeholder groups, we're going to run into trouble. Either the implementation will stall, it won't spread, it'll be abandoned. Has anybody here seen a great quality improvement project that did good thing and improved care, and down the road it just died for lack of support, ostensibly because it wasn't really in the financial best interest of the organization? Has anybody ever seen that? I mean, having done a number of chronic care collaboratives in primary care groups with really no business case, those were great interventions. So many of them died for lack of a long-term business strategy. Other stakeholders to consider in the community, purchasers, health plans. As we have reform in the healthcare market, these are critically important stakeholders to think about. So as you look at implementing Choosing Wisely, whether considering which recommendations to do and how you do it, I would counsel you to take some time to think about this. Very valuable. So to that end, here's one of the recommendations. Don't screen women older than 65 years of age for cervical cancer who've had prior screening and otherwise are at high risk for cervical cancer. How does this stack up against that? It's fantastic. When I read this, before Choosing Wisely came out as an internist, I thought I'd died and gone to heaven. Have any of you ever grown up in an age of doing pap smears on older women with no guidelines whatsoever when to stop? That was horrific. And so this is an example of a guideline that's sticky. And in fact, this is probably widely implemented in most of our practices. It's a win for patients. It's a win for providers. And there's really no adverse effect on the bottom line of the organization. So this is the kind of thing that should be easy. And in fact, I think if you look around, it's probably pretty rare that we don't do this. The other one that I thought was really, wearing my internal medicine hat, quite lovely, is a recommendation not to use additional medications to push hemoglobin A1C below 7.5 in folks over 65 from the Society of Geriatric Medicine. Again, if you look at that against these criteria, are patients going to love that? Absolutely. Less pills, maybe less testing, maybe less doctor visits. Am I going to like that as a clinician? You bet. I worry less about hypoglycemic reactions. My day is too busy, and I got plenty of other work to fill the capacity that this might free up. Is this financially adverse to my practice? I don't think so. Or to a health system? I surely don't think so. So this is an example of a guideline that everybody is kind of ready for. It's not going to run into much trouble. And as you think about implementing, my advice is, A, start where it's easy, but B, think through those different stakeholder reactions and then use that in terms of rolling out and building support. How about the recommendation of don't use benzodiazepines in patients over 65? Strong recommendation, probably very strongly evidence-based in how important this is. Ever tried to do this? It's a bloodbath. Okay, you have somebody who's been using benzodiazepines for anxiety or sleep for years, maybe decades. And then you say, you know, Mrs. Jones, we really need to stop this drug. Not that it isn't the right thing to do, but there will be tremendous patient pushback most of the time, and frankly, a lot of challenge for providers. A great recommendation, probably not where I'd start. Any comments or questions on just the whole concept? Okay. Leverage alignment. Again, choose both recommendations and system changes that are aligned. It gets you moving, keeps the work way down that we need to do. Think about alignment in terms of your organizational culture. Big differences in provider organizations and what's a fit, both in terms of what you do and how you do it. Alignment with existing initiatives is super important. Again, our bandwidth on the provider side is already exceeded by regulatory requirements, reporting, quality improvement initiatives, credentialing, so much stuff that there really isn't a lot of space for new things. So to the degree that this implementation can overlap with things that you're doing, that the community is doing, maybe the hospital association is already working on something, maybe the state medical association, maybe your organization. So try to find those alignments so we're not creating new work as much as building on the effectiveness of work that exists. Leverage available data. I'll give you some examples of this in just a minute. But data is expensive. We're being asked to be more and more data-driven, more and more quality improvement. If you're looking for a starting point, you're looking for much more rapid change, leverage what you have. And then recognize and leverage the interest or the passion of your clinical champions, your leaders, formal and informal. We'll cover a couple examples of implementations that have been very successful or in process. Most of the shining examples so far in Choosing Wisely changes and implementations are tightly aligned with some clinical champion's passion. So look through your organization, see who's effective, see who's got passion, and that may actually largely inform where you go or how you go there. Provide useful data. Most of you understand this concept well. Data will first help you identify ripe opportunities. Where's the big opportunity in terms of improvement? It will absolutely help you build will if you can articulate the problem. It will help you mobilize resources, not only financial resources, but leadership resources. Often the barrier to getting things done. Use data to demonstrate value. As changes roll out, measure what happens. And if we're fortunate, we can demonstrate that as value using some aspect of the triple aim. And that value, of course, will reduce resistance going forward. It will facilitate spread and assure sustainability. Again, the nightmare for those of us who work in process improvement, quality improvement, is seeing good work die. Successful improvements die for lack of support going forward. And obviously, data is useful to identify best practices for learnings and challenge practices for extra support and remediation. Comments or questions on this? Build the business case. This sometimes feels like a fairly cynical perspective in quality improvement circles, but absolutely your job is to at least understand, if not articulate, the business case. And think broadly about return on investment. You know, the obvious ones, including hard costs, employee time saved, are real. But think also about provider and staff satisfaction, patient satisfaction. Those things have real value, somewhat hard to monetize, but real value. Think about revenue sources. How can Choosing Wisely actually improve revenue stream? Can anybody think of an example of how that's happening now or how that could happen? How could this work improve revenue? Give you an example from, yeah, please.
There's multiple ways that it could work to improve revenue. I mean,
Can you stand up while you?
sure.
Yeah.
So I'm Ted Conklin from Primera, and we've been looking at the data and looking at ways of being able to measure adherence to recommendations and the activity that various groups have involved with this. One of the things we're looking at is what is the return on investment when folks do a great job of following the recommendations compared to what things look like when they're not. So obviously, improved health overall reduces costs over the long run, and that is a big return. But from a provider reimbursement standpoint, you know, we talk about the CFO being able to be satisfied with the initiative. And I think from a payment perspective, the folks who are paying for health care and paying for better health care and better outcomes should pay for that activity. And I mean, we're firm believers in making this work out because, again, we're all aligned in this initiative. It's a win-win-win. The member wins, the employer, the self-funded employer, the plan wins, and the docs need to win from a reimbursement perspective.
Great.
So I think there's lots of good
Lots of
returns.
potential.
Yep.
Thank you. Any other examples? Yeah, please.
Bob Mecklenburg, Virginia Mason. So as we've implemented these types of processes, what we've noted for revenue is increased throughput of patients. This might be radiology, it might be office visits and so forth, and often with more complexity, so the charge codes can be higher. It's also attracted new patients, new purchasers to the organization when they see this. And finally, it reduces our cost of producing care. So it's not a revenue, it's a cost reduction model. But all three of these things have been of financial benefit to us.
Great. Thank you. So the point, I don't want to belabor the point, but again, as system leaders, to make this work and make this stick, we need to be thinking this way. And I want to actually, Bill, you feel free to jump in here. The foundation and the ABIM has been very clear that this is not about cost savings. This is about improving patient care. And so I want to be sensitive to that and honor that. But in the role of thinking how we make investments to change systems, my counsel is we need to think about it as healthcare leaders, but the foundation has been intentionally steering clear of that. Is that a fair statement?
Well, I think the foundation and the board are in favor of cost reduction as long as that's in the patient's best interest, which the argument is.
It is. Yeah, okay, thank you. And so the last example from our market is with healthcare reform coming, the Affordable Care Act. Many of the health plans are choosing narrow networks. And how do they do that is the question, especially the new ones that have just popped up. And frankly, a lot of them are using some of the evidence-based reports that come out of the Quality Corporation in our market. Health plans are starting to use this stuff in contracting. When we sit down as a medical group, wearing my medical group hat, to talk to a health plan, we bring our data. And we say, here's our data. You know, you have what you have from claims. Here's our data and what we're doing. And we expect a better reimbursement rate because of this. So just trying to, build support for this is where I'm going. Yes, please.
I think another factor is nowadays patients are carrying more of the cost of care.
Yes, thank you.
And so patients are asking more questions about how much things cost and why do I need this? And so I think that the idea of shared discussion, the shared discussion is critical because it's both for the patient's best outcome, but if we don't follow evidence-based guidelines, the extra cost is often borne by the patient.
Absolutely. Thank you. Okay. Teresa, how are you on time so far? What time is it? What time is it? Ish. Okay.
Yeah, we have about 15 minutes.
15 minutes. Thank you. Lastly, I won't belabor this, but supporting behavior change. Make the right thing to do the easy thing to do. That can certainly come up through many different ways, including your culture. I think the thing I just want to highlight, again, that's probably not news to anybody, but it's very easy to build things like hard stops, a lot of decision support that actually slows down your throughput. It slows down your workflow, usually falling on the back of your providers, which is a precious resource. So just to think about that. So I'm going to give you 3 examples in various degrees of specificity and development with increasing robustness as we go down. And again, the idea here, the purpose of that is to seed ideas and get you thinking about what may work in your organization. And the first example, which is going to be very general, is using patient-facing educational materials. That's a system change. It's relatively easy to implement. The fortunate thing here is the consumer union handouts are are very, very good. And this is just a quick snapshot of them. In particular, This is not just about why you don't want to rush to antibiotics. There's lovely information here about how you do treat rhinosinusitis. So it's not just a don't do this. It's very solid patient information created in this case by AAFP, family physicians, about how should we treat sinusitis that does not require antibiotics. So a great tool. It's free. I know Dr. Buist is going to talk about this a little bit more and its use at group health, so I won't go too deep into this. But great opportunity, and again, this helps support your physicians who sometimes wind up in long and difficult conversations. This can really be used to improve the efficiency in that situation. And again, in terms of talking, not measuring, but talking to different organizations, practices are trying this primarily when rooming patients or after visit. Some are actually looking at coupling this with phone advice, nurse triage phone advice, because these are available online, available in PDFs. Don't have any data on that. Hopefully you can give us a little bit of what you know about the evidence base around this. So starting with a fairly easy, light intervention. Telemetry redesign. The recommendation out of the Society of Hospital Medicine is that continuous monitoring outside the ICU should be based on diagnosis and should not be ongoing. Rob Dressler has done some phenomenal work, and I want to thank him for his permission to use this at Christiana Healthcare System in Newark, Delaware. And I've got sort of a high-level review. So the case for redesign, they did a call log analysis and found that less than 1%, everybody know what continuous monitoring telemetry is? Anybody need me to explain that? Okay, ongoing hospital monitoring for heart rhythms, less than 1% of the alarms were actually for emergencies. 60% of the calls were for leads coming off. The problem that all of this causes is, first off, frequent nursing interruptions. Errors go up with more interruptions. Stress goes up with interruptions. It's a difficult system design for reasons most of you will know. Alarm fatigue decreases nursing responsiveness. When they did a time study, 19 minutes and 45 seconds per patient day on the average RN, real cost there. There's a lot of patient discomfort in being monitored. Sleep disturbance, not the least of which. Significant satisfaction issues around this. And when they did a cost study, pulling it all together, $53 per patient day, 5.4 million system-wide. So what did Christiana just do here? Pulled some data, made a very nice problem statement. You can begin to see the business case emerging. And they're thinking about different stakeholder groups. So they're using some of those key principles as they think about how to build this intervention going forward. So briefly, this intervention, and Rob Dressler is more than happy to share information with folks in more details. I have a limited slide set because this is being submitted for publication, and he didn't want the data to be too widely disseminated. But the intervention in brief is the ordering physician or clinician must specify the indication. There's automatic stops based on indication, most of them at 24 or 48 hours. To sort of reassure physicians, if an order is going to be stopped, they're prompted in case it might need to be resumed. And this is hardwired. This is all in the computerized physician order entry system in the hospital. So it's very much automated. Here's a screenshot of the order entry, and you can see over here the couple indications that allow continuous monitoring without re-up, including post-open heart surgery and things like that. A set of services that stop at 24 hours, a set of services that stop at 48. The physician checks the box. It's relatively easy. It's relatively straightforward. And there's not a prior auth step. There's not a permission step, which means it really didn't encumber workflow too badly. But this is beautiful because it is decision support. It gives suggestions to clinicians. But look at the data gathering opportunity here. Think about this. You can see which types of indications are getting reordered. Maybe those stops aren't the right ones. Which clinicians are significantly outside of guidelines. A lot of data comes back that's actually tremendously useful. So how did this work? The results were actually fantastic. There was a 40% decline in overall orders. Total hours dropped by 69%. I was pretty much astonished when he presented that number, but I think it's real. 69% drop in total telemetry time. And monitoring adverse event rates, they did not go up. So this really looks like good data. It's been submitted to peer-reviewed journals, so I suspect it's real. But that's very dramatic. This is a statistical process control chart that's not in your handout. I was asked not to distribute this, which is why it's not there. But this basically shows a tremendous drop at the intervention, the blue line being total telemetry time. So an example of taking a Choosing Wisely recommendations, turning it into a system change with phenomenal results, both in terms of the provision of the service, but the vitality of the organization. The second example I want to give you, or the third example, excuse me, is a little bit less built out, but we'll have an opportunity to learn more about that. And that is a decision support module that's built and embedded within Epic to prompt physicians, providers about the Choosing Wisely guidelines at point of care. This is led by Scott Weingarten at Cedars-Sinai Medical Center. And he recently did a presentation to the Epic work group. And briefly, they, in conjunction with Epic, built this module that pulls data from the flow sheet, both clinical data, diagnosis data, pharmacy data. And to the degree they can embed those recommendations, prompts are in the EHR at point of care asking providers, physicians to do something different. I believe that they initially embedded 120 guidelines. Can you imagine that? 120 guidelines, you can imagine that. I can't. Not only building it, but can you imagine being a practicing physician the day they turn that on? Ouch. Or can you imagine being the clinical champion, the physician lead in charge of this project the day they turn that on? Anyway, there's more to that story that I'm going to let you learn somewhere else. In the end, they actually dialed down the intervention so it was much easier to override these because of the problems to workflow. The results are immature. The pilot was really rolled out in September. The initial feedback from clinicians, as you can imagine, was fairly negative because the prompts included a paragraph on what to do and why. A paragraph. Imagine being in clinic 20 minutes behind, if you're lucky, having to click through paragraphs in order to review things. And I believe, don't quote me on this, they turned on all 120 at once, I think. But don't quote me on that. Feedback cycle, learning cycle, they've decreased the recommendations to one line with a hyperlink to supporting information. Override reasons, it's relatively easy to override. But again, think about the rich data source you get with that override data. Who is doing overrides? For what indications? For what services? For why? It's just tremendously rich in terms of going back and understanding, A, your culture, B, what's being done and how to fix it. For talking with him briefly, currently there's actually very good provider support for this. Interesting, the most frequent alert was, look at that again, benzodiazepines in patients over 65. A very important recommendation, but you can begin to see some patterns in your organization. And they're planning to obviously create tools to support physicians in doing this, which, as I said before, as a new drug, that's an easy thing to do. As an established drug, that's a fairly hard thing to do. Most, and back to revenue. I asked that revenue example before. This intervention satisfies meaningful use stage 2, which gets you right back to revenue. So an example of how you can find that win-win-win by doing the right thing. So here's the opportunity for you, Choosing Wisely, not as part of this particular program, but the national, convenes a health systems leader call. It's a phone conference. I think it's every 2 months. It's been going on even before this particular grant came out. The health system leaders call is a great way to learn what other organizations are succeeding at. So that telemetry intervention I showed you with Rob Dressler was presented about 6 months ago on a leaders call. This month, October 30th, 11 o'clock our time, Scott Weingarten will be going through this EPIC module, how it was developed, what it actually is, and lessons learned and the data. So I'd encourage all of you to consider this. This is another slide that's not in your deck because I just learned about that this week. And I'm wondering, Teresa, can we push this out to the group? So you don't need to scribble this down, you certainly can, but we'll push this information out. And if you have interest in either joining the Leaders Network, great opportunity. I encourage you to go to do that, or just interested in this particular intervention, I would. Probably not a good idea to recreate the wheel. I know most of you in the room are probably on EPIC or moving there sometime soon. But I think the work's been done. It's very robust. I've seen some of it, so it may be actually a good opportunity for you. So the last comment before I'll pause is, Teresa asked me just to bring some resources for you. Many of these things are online. Choosing Wisely has a website with the recommendations. ABIM Foundation has a big piece on Choosing Wisely. There's a blog run by Daniel Wolfson that includes the Choosing Wisely conversation and other issues around medical professionalism. The Consumer Reports patient education information is all accessible here to look at, along with some other things. The Health Leaders Network call I just showed you. And the last bullet there is Choosing Wisely is developing modules to train physicians for patient-physician communication around the difficult issues that come up in Choosing Wisely, about things like overuse. Those were created in partnership with Drexel University Medical School. They're in final kind of production and approval and copywriting. Those will be available next month. And they are in the public domain and they're free. So if actual video training for your providers is of interest, that's coming soon. With that, I think I'll stop and invite questions. Thank you, Susie. Questions, comments? Thank you.
I attended that Epic user group.
Oh, please.
What was amazing.
You were there and I
Yeah, I
wasn't,
was there.
So go ahead.
And what was amazing, they were able to track which physicians were doing what.
Oh, yeah.
Yeah, so they could see that some physicians were doing benzodiazepines regularly, and they could have one-to-one conversations and modify behavior if they wanted to, or at least get an explanation. Or if they had repeat offenders for CAT scanning. So it was a very robust, and you're right, they were just starting, and there were a lot of negative, there were some initial negative problems with their providers, but they're pushing through with it. And you're right, they did turn on all, I thought it was 140, not 120.
Okay.
So it was, yeah, so you're right.
And what was the feedback on the, they call it the Big Bang approach to that. And how did the Big Bang go?
No, it didn't go so well.
Yeah.
Yeah, so they had to scale back a little bit.
Yeah.
And, they had to, remind patients that, their physicians that it was a conversation more than anything else.
Yeah. Thank you for adding that. Jonathan.
So I have a question about your win-win-win suggestion and approach. And you gave a couple of examples of things that were either wins for everybody or not so much for others. Has there been any systematic effort to either try and assess a priori which ones are in the win-win-win category, or alternatively, it might be nice to kind of start collecting data as people implement them? We heard from Dr. Bremner that there was a pushback from some proportion of gastroenterologists who didn't want to hear that you shouldn't report repeat colonoscopies every 10 years unless there's an abnormal, or upper endoscopies less than every 3 years for Barrett's esophagus. That then, I presume, would be an example of the some category of not winning. Any thoughts about that, or is there any assessment activity going on about that?
Great question, thank you. And the answer is I don't know. It's pretty early on. Again, most of this has been really a campaign designed at awareness. There's measurement going on around effectiveness of certain methods for disseminating. There's some measurement going on around consumer tools. But for that particular example, I don't know the answer. Dr. Buis, do you have anything to add to that about the evaluation component being your area of expertise?
Sorry, I think that there's still a tremendous amount to do around the evaluation components of these materials. I'll talk a little bit about that. And we're definitely looking for partners as well in terms of who would like to have those evaluations done.
Yeah, no, it's a great suggestion, and at least anecdotally, we are trying to track what's being done, at least in terms of successful implementation. Step sideways for a brief plug. One of the products coming from ABIM Foundation is a collection of successful implementations, which we'll probably call the implementation guide, which will basically be stories and data where it exists. So that's ongoing work. If you, in any of your work, become aware of that, please send me an email so we can do an interview and start to collect those to share more broadly. That's not really getting at your question, except to say with time, we'll see what works, we'll see what sticks. My intuition is those things that don't get very far may be more in that much more difficult to implement range. So, one more question or comment. Thank you.
Yeah, I'll comment on this because I won't have time during my presentation to comment on this, but this is, I think, of interest for what you just presented, David, is that if people are interested and organizations are interested in the consumer reports material, there is actually a process by which your organization or your group of providers can get those materials, and they are all available for free, but they do require signed agreements with consumer reports. And as part of that, they collect quarterly information on who has access to them and what the hits are on those. So that's as much as I know about how much Consumer Reports is getting data actually on the use of these materials. They don't have a systematic way beyond that for collecting information or on how effective they are. But Group Health actually learned about those materials when John Santa came, when Puget Sound Health Alliance brought him here, and we then signed an agreement with them. So if anybody's interested in learning how to do that, I'm happy to talk further about that.
Great. Thank you very much. Well, thank you for your attention, and look forward to the rest of the afternoon.